am Dr. M.K. Basu, a diabetologist by profession. Today, we'll be going to discuss the latest update in hypertension. First, a brief introduction. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to CVD, cardiovascular disease, which affects 45% people in the age group of 40 to 69. Raised blood pressure is among the four most important risk factors for cardiovascular disease. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through the primary care, and poor follow-up. In India, the prevalence has also gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. It means from 29 to 38 and from 28 to 32. It has been increased during a course of time, 30 years. WHO, despite that, nearly half of the people of 51% of the men and 41% of the women with hypertension were unaware of the condition. Additionally, over 62% men and more than 53% of women living in hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 women with hypertension worldwide. This information is given by WHO, World Health Organization. International Society of Hypertension has released ISH 2020 Global Hypertension Practice Guidelines, which includes the inclusion of optimal and essential treatment paradigms attempts to address the issues that in resource poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refer to minimum standards of care to allow specification of essential standards of care for low resource settings. The American Heart Association and American College of Cardiologists has released a scientific statement in 2021 offering new guidelines for management of the stage 1 hypertension. It means no atherosclerotic cardiovascular disease or 10-year cardiovascular disease risk factor less than 10%, with stage 1 hypertension where the blood pressure in between the systolic is 130 to 140 and diastolic is 80 to 90. Management starts with non-pharmacologic therapy. That means no medicine is required if the blood pressure persists in between these range. If blood pressure remains uncontrolled at 3 to 6 months, considering started pharmacologic therapy. Acute respiratory distress syndrome, in short ARDS, is a potentially fatal condition involving lung damage, and experts often associate it with severe COVID-19. A recent study shows that metoprolol can reduce the lung inflammation and improve respiratory functions in people with COVID-19 induced ARDS. So, beta blocker is helpful in COVID-19 ARDS. Lowering systolic blood pressure targets down to 110 to less than 130 millimeter range substantially reduced cardiovascular adverse events in the STEP randomized trial, affirming the sprint finding of an older Chinese populations. Among some 8500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite cardiovascular risk findings. From now, a second major trial supporting a low target could unite the guidelines, which even among US professionals society ranges from threshold to 130 to 150 millimeter of mercury. With regards to prognostic value of ambulatory blood pressure monitoring, the diagnosis of hypertension should not only be dependent on office BP measurement, but also on out of office measurements such as home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of cardiovascular outcome. For every 20 by 10 millimeter of mercury increment of blood pressure measures at night, the risk of mortality increased by 23%, and the risk of cardiovascular events increased by 36%. Most patients with hypertension require lifelong medical therapy to achieve the optimal blood control. In 2018, European guidelines equally recommends 5 classes of antihypertensive drugs Considering high non-adherent treatment, the importance of combination treatment is particularly highlighted to improve adherence. 2018 European guideline recommends, especially in the context of lower BP targets, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or ARB plus CCB or diuretic. Since early July 2018, products containing valsartan have been recalled worldwide. The reason in the detection of a known carcinogen, namely NDMA, N-nitrosodimethylamine, which can be found in candesartan, irbesartan, losartan, olmesartan, and valsartan, nearly all sartans are involved. NDMA has been classified by the WHO, International Agency for Research on Cancer, to be carcinogenic in humans. If 1 lakh patients would have received NDMA contained valsartan every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients. The HYGEA studies represents the largest study that tested nighttime antihypertensive treatment. The HYGEA chronotherapy trial tested whether nighttime therapy in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest study included of total 19,084 hypertensive patients during an average follow-up of 6.3 years. 1752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how the BP differentiated during sleep. The relative risk reduction for CV events was significantly improved nighttime treatment when compared with awakening treatments. This is all. Thank you.